Hi, everyone. Good morning and welcome to the Drug User Health Symposium. We're very excited to welcome you here today. And thank you very much for your patience. We had a bit of a login issue with Eventbrite and people were having trouble getting in, but it's been resolved. And so we're going to get started. I'm Shelley Facenti. I'm your moderator for today. And I just have a couple quick housekeeping items before we have our official welcoming talk. So this is a webinar. That means that you are automatically muted as participants, but you can use the chat, both to chat to your other attendees or to share information. If you have specific questions for the panelists, instead of using the chat feature, please use the Q&A feature at the bottom of your Zoom window. And that will allow us to see your question and prepare for the panelists, because I'll be moderating questions throughout the sessions. Or you can raise your hand to talk. And in places where we have longer periods for Q&A, if you raise your hand, we can actually unmute you and let you ask your question, although you won't have video. So that's the webinar information. The only other thing I wanted to say is that we are recording these sessions for anyone who wasn't able to make it. So this is being recorded. All right, with that, I would like to hand it off to Eileen Loughran from the San Francisco Department of Public Health for our welcoming talk.
Good morning, everyone, and thank you so much for joining us today. Over the next 2 days, we hope to share some best practices, some lessons learned, and some challenges that have helped us be better community partners and to really understand working well with the community partners and with the community that we serve. It's really important that for me to recognize that I work for the government. As a government employee, I have a lot of power. I often get asked to speak at commissions or before the Board of Supervisors or other things that can really influence policy decisions. But to do that work effectively and well, I really need to have an understanding of the programming and of the people that we serve. And I think that it's important to note that balancing those two roles can be hard. And it takes a lot of humility to recognize that as a government employee, we're not always the experts when it comes to on-the-ground programming and what's happening. And that's why it's really important to get out there and really understand the programming and show up. So if it's raining, well, I'm still going to be there because that's important. That shows that I'm committed. If I show up at a Syringe program and they say, oh, you're rolling Brillo today, and we all know rolling Brillo isn't exactly the best project, I'm going to do it because that's how I'm going to understand and better know the programming, because that will inform any of the work that I do before the Board of Supervisors or before the mayor's office or the health commission. So throughout the next 2 days, we're really going to emphasize the importance of working closely with your community partners to really ensure that we include the voices of the community, whether it's people who use drugs or our community partners. That means when we say we want to show up for a site visit, well, we have to practice harm reduction. We have to meet people where they're at. We don't show up in our fancy government clothes. We show up with our hoodie and are ready to just jump in and do the work. We don't show up unannounced. We ask, hey, I'd like to do a site visit. Can I show up? We respect the boundaries, and that means not just engaging with participants without having that connection from our community providers, because we have to realize that that can have a negative impact, not only on our community programs, but also on the people that we are trying to serve and reach. It's really about respect and humility to go and recognize that we're not the experts and we are trying to learn. I've been very fortunate that the community providers in San Francisco have been such a wonderful partner for me and have really provided an opportunity for me to learn so much about the programming and working with people who use drugs. So I feel in confidence that if I do get asked to speak at a board, I am truly representing the program, and that is key. So if there's any takeaway from the end of the 2 days, I ask that you think like, how can we be more inclusive in the work that we do to include the voice of people who use drugs and our community partners? Flexibility is really key. So we know as the government, we often have 9 o'clock meetings in buildings that have security guards, or where you have to sign in or you have to flash a badge. Well, if we want to be inclusive of people who use drugs, that's not going to work. We have to really step back and think, how can we create an environment that will be welcoming to everyone? And that might mean that we're meeting at one of our community programs. That might mean that we are meeting at a cafe. That might mean that our meeting will be at 3 o'clock in the afternoon instead of 8 o'clock in the morning, because we want to include the voice of our community. We all have so much to learn from each other. And again, as I said, I have learned so much, and I continue to learn so much from all of the speakers today and our community partners. And I think that if I'd highly suggest is just really having that flexibility and that openness of working closely with community partners and really thinking through how to include the voice of people who use drugs in your programming to how best meet their needs. So with that, I am going to turn it over to a short video of the Director of Public Health, Dr. Grant Colfax. Thank you very much. And again, thanks so much for joining us.
Hi everyone, I'm Grant Colfax, Director of Health for the City and County of San Francisco. And although we cannot be together in person today, I wanted to take a few moments to welcome you virtually to San Francisco and our Drug User Health Symposium. The health of drug users has always been a priority in San Francisco. But now, more than ever, we continue to confront the challenges that make it difficult for drug users to stay healthy. As an example, in the first 8 months of 2020 alone, we tragically have lost 470 people to overdose deaths in our city. The reasons for this are multifold, including an increase in fentanyl use and the COVID-19 pandemic. But we are also making progress. Thanks to our collaboration with the DOPE Project and our robust naloxone training and distribution programs, we have reversed over 2,200 potential drug overdoses in San Francisco. We need to keep up this good work and strengthen our partnerships. I'm sure you are looking at similar work in your local jurisdictions. I'm really excited to see the agenda for this Drug User Symposium and encourage you to take the time over these next 2 days to really focus on the learnings, the collaborations, and the work that needs to go forward. In closing, I really would like to thank Eileen Loughran and the entire San Francisco Department of Public Health team for their work in supporting this symposium, as well as the National Harm Reduction Coalition and Vicente Consulting. Thank you, welcome to San Francisco, and have a great symposium.
Thanks so much. Thanks for that welcome, Eileen. And we're really excited that Dr. Colfax was able to join us even by video for this morning. So now we will move into our first keynote talk of the day. We have Laura Guzman here, who will be sharing information about a little bit of history, a community-based perspective.
Thank you for unmuting me. Good morning. I'm going to take just a second to start my slideshow. Good morning, everyone. I am Laura Guzman. I am the Senior Director of Capacity Building and Community Mobilization for the National Harm Reduction Coalition. And I feel so excited and privileged both to be sharing with you and representing NHRC in our long-standing partnership with the Department of Public Health. A little bit of this history of the San Francisco community model is that I was in San Francisco at the beginning, and I was a learner of the harm reduction pioneers that really
For the city and county of San Francisco. And although we cannot be together in person.
Grant is competing with me, wait. So I am very delighted to say that I was one of those people that were mentored by the pioneers of harm reduction, which actually was born in the Bay Area in the early 90s. A little bit about the National Harm Reduction Coalition. We'll be sharing some spaces in today's video. We are an organization that was founded 25 years ago to create spaces for dialogue and action that help heal the harms caused by racialized drug policies. And we engage in policy and advocacy, national and regional conferences, training and technical assistance, overdose prevention, and most recently, grant making. We have an initiative in the South called Hep Connect, an initiative in California called Cherry. One of the ways that we partner closer with the Department of Public Health is through our HRTI. So we have a particular harm reduction training institute that we do together, and also the DOPE project, which you will hear more, which is one of the oldest overdose prevention and intervention programs in San Francisco. I wanted to share a definition. So although we say there's no one definition, because we really are always attending to the individual needs of drug users and the communities, but we would like to share some definitions that can move us throughout the today's. Harm reduction incorporates a spectrum of strategies that includes safer use, managed use, abstinence, meeting people who use drugs where they're at, which already was shared with Eileen, and addressing conditions of use within the use itself. And this will become a little bit of a metaphor as we go through some of the discussions, because as Dr. Colfax just shared with us, the advantage of fentanyl in 2018 in San Francisco, along with this incredible rise in overdose death, also goes along with a lot of other impacts, systemic impacts that our communities who use drugs have and have had. And I want to show you through the history that in some ways what started as an incipient movement in 1995 with the overwhelming deaths of people who had AIDS and were using drugs, we are seeing again this challenge. We come into harm reduction work from different places, our own personal experiences with drug use, our love or grief for family members and friends, our professional experience and commitments, and our exposure to injustice. And with that, I wanna share a very brief, rich history of the harm reduction in San Francisco. And I'll start with actually a beautiful picture in Oakland, California, because the pioneers of harm reduction in the United States actually was in San Francisco in 1993. There was the first harm reduction working group, and there were folks across the country that were determined to address the fact that people who use drugs that were dying of AIDS were not being served, and that the spread of the infection was incredibly impacting in the community who use drugs. In 1990s in New York, 50% of all infections were among people who use drugs. So in this picture, I'm gonna just mention 3 people that are really dear to me, but also people that made a tremendous difference in the way that we have been handling HIV and HCV epidemic, and even overdoses. So in the very bottom is Dan Big, rest in peace. And Dan was, we call it the godfather of harm reduction. And he was the one who coined the term any positive change. As harm reductionists, we're true believers that any baby step in the right direction of health, it's very valuable. And also Dan was one of the champions of injectors health, and also one of the first to really start passing Narcan in the hands of community. And the other person I want to mention, you see kind of in the middle, Sister Imani Woods. Imani was in many ways one of the most relentless advocates on behalf of Black and people of color communities impacted by drugs. And Imani was one of the founders as well of the Harm Reduction Coalition, and someone that if you're inspired is to go and search for Imani Woods, and you'll see some amazing perspectives on what it was to talk about harm reduction in the Black community, given the incredible impact of the war on drugs in the Black community. And then on the top, in the middle, is John Paul Hammond. And John was the founder of Prevention Point in Philadelphia, but John was one of the first people I met in San Francisco who was really pushing for a drug users union, which you'll very soon hear about the development of an amazing organization called the Drug User Union. So I wanna honor all these pioneers and also our ancestors. And then in some ways, all of these things are really brewing in San Francisco. And those of you who know San Francisco, we're the troublemakers, right? We're the big troublemakers in the United States. And there was a lot of community empowerment and organizing for health access, and definitely in the AIDS epidemic. But I want to go a little bit back to the late 60s and 70s, where also Black community, Latinx community, Native Americans, we were all fighting to have access to healthcare in San Francisco. And that was actually the beginning of our community health centers. The Mission Neighborhood Health Center, where I worked for 16 years, was one of the first in the country, 1967, fighting for that access. And so what we see at the beginning of the AIDS epidemic is that the same impacts that the Black and brown communities and poor communities was also now impacting HIV, the tremendous impact of HIV AIDS in the gay, lesbian, and transgender communities. And what you see here was actually a gathering at the National AIDS Conference in 1990 in San Francisco. I also want to say that critical to the remembrance of who really inspired the movement is people with AIDS themselves, that were really at the forefront of making sure not only that all people with HIV had care, but in particular, people who use drugs. And that moves me to my crash course in harm reduction. This is where I was exposed to all of the mentors. These pictures are at the Ambassador Hotel, 55 Mason. And I was gonna put a picture of the building, but I decided to put these two amazing pictures of photographer Paul Fusco. And these were taken at the hotel where we were serving 150 people dying of AIDS who use drugs because no other program will take them. These were folks that were injecting heroin and could not be in a hospice, or there were folks who otherwise will be on the streets. And it was two people with AIDS and LGBT warriors, Hank Wilson, rest in peace, and Tom Calvanese, along many others, including nurses, who then worked for DPH, and social workers that created this model of wraparound services. We all came together to help those folks that were dying in the hotel and were impacted by drug use. I gotta say, this is what I learned, the ropes. In some ways, what Eileen says, I learned from the people themselves, what worked for them, what made them feel heard and felt supported throughout death. By the way, if you have time at any point, there's a beautiful YouTube series, was a program by K-Ron, Channel 4. It's called Life and Death in the Ambassador Hotel. It's very worth looking at it, because we can see a perspective of what that looked like at that moment and what people were going through. And in some ways, we're seeing a new moment of massive death that we need to go back to what we know. And I want to mention nurses, because San Francisco nurses were some of the first city harm reductionists. And here is my mentor, Dion Jones, who worked at Ward 86. She was a baby. And these nurses in San Francisco were real pioneers of care to people with HIV, but also to people who use drugs. And in fact, they really move the agenda for the Department of Public Health and for the community to say, we need to take care of all our folks. And that included people impacted by drug use. And actually Dion was one of the first harm reduction working group leaders in 1995. That is when I got really the beginning training on what harm reduction and helping people look like. And then there's the housing and harm reduction history parallel to the first underground San Francisco Syringe exchange program. It was called Prevention Point. And this is again, rebels in San Francisco saying, we are not gonna let our community die. And they actually developed the first underground needle exchange, I think for 4 years, that actually kept the community, at the time was an exchange, then it became a distribution, and that resulted in today, the San Francisco AIDS Foundation, incredible, needle exchange, syringe service programs that you're gonna hear throughout the 2 days. But that was the other, and this is again, 1993. And I want to say something about clean needles, save lives. And I think Eileen already talked about this a little bit, but it's very interesting that in this country, we still debate, it's one of the most debated topics on healthcare, is the idea of whether or not it's a good idea to exchange needles. But I want to say that it's the most thoroughly studied public health intervention of the past 30 years. And so in some ways, when people ask me why there's still this feeling that this is not right, I said, I don't know. It is proven that it works. And it is also a needle exchange in our programs. You're gonna see them in amazing videos, and you're gonna hear from the community that serves our folks. It's the sole path to treatment and access to medical care for many of our folks. And it's also an ambiguous and critical determinant of health. So I just wanna say, the syringe services access saves lives made San Francisco early on to embrace, and in particular the department, to embrace this particular form of harm reduction as a critical piece to not only address and prevent HIV and HCV, but also to really build community. And so very briefly, and this is really a very brief history, the Prevention Point was founded in 1988. And at the same time, we were doing the ambassador model housing harm reduction for people who use drugs that were dying of AIDS. In 1993, it was in the Los Angeles Times an announcement. It was a big announcement. Mayor Frank Jordan declared state of emergency and formally sanctioned syringe access. Actually, that was the first award of about $130,000 to Prevention Point. I also wanted to highlight that in 1997, we obtained in San Francisco one of the first special projects of national significance to house people who were triple diagnosed. I was part of that project, and that was a collaboration between community-based organizations and Tom Waddell Health Center, one of the DPH clinics, and that was a fabulous project to show that when you house people who use drugs, actually they recover, they do well. And then you see a laundry list, and I'm gonna just, the most important to highlight is, again, both the housing and both who were doing housing and we're doing syringe access at the same time. And actually San Francisco was one of the first in the country, Department of Public Health, to form a housing and urban health that actually developed housing for people who had substance use as part of their diagnosis. And then in 2000, the Health Commission passed the resolution. It was Dr. Josh Bamberger announcing that the city had officially, the department had officially adopted harm reduction. In 2001, our National Harm Reduction Coalition DOE project began piloting training of community and government partners in overdoses. And we used to do the rescue breathing. I remember my first training did not include a Narcan. We were doing all the hard work to make sure that if people were passing, we were gonna be there to save them. 2003, SFDPH began to provide prescriptions for naloxone. In 2009, the San Francisco Drug Users Union received its first grant, and you're gonna be here tomorrow from Ms. Yen, all the fabulous work of the Drug Users Union. And I move it all the way to 2020 because I have to conclude my presentation. But during COVID, the partnership between the Department of Public Health along the San Francisco AIDS Foundation and the DOE project in setting overdose prevention intervention during all of our shelter-in-place sites was just unbelievable. And I want to give kudos again to Eileen Lugran, who is a pioneer and a leader, making sure there is harm reduction everywhere in the city. I just want to say some of the challenges will be presented. We already heard Dr. Colfax about our death numbers, but also our reversals. And I also want to say we are really challenged, like the rest of the country, with increased homelessness and lack of housing, which exacerbates substance use disease overdoses and COVID-19 interventions. And in addition to the coming of fentanyl to San Francisco, we also lack capacity in drug treatment and we are still impacted by systemic racism. And these are all the things that I feel as we move forward, we should really be taking a look upon. One is to, as Eileen mentioned, how do we assure the meaningful involvement of people who use drugs? We want to affirm their wisdom and their leadership because they really hold the key to transformative change. And in this picture, you see the first founding of the Drug Users Union in their little first place in the Tenderloin. And now we just had our No Overdose campaign, highlighting messages from communities impacted by drug use. Also, how do we shift power and resources to people and communities most vulnerable to structural violence? So a real focus on Black, Latinx, and Indigenous communities, LGBTQ, and other most impacted communities is a must. And also, how do we hold these harm reduction programs as essential partners? As Eileen so well said, crafting this partnership is critical for public health to make a dent in the life of our communities. And I want to say, when you see these pictures of the DOE Project, Homeless Youth Alliance, and San Francisco Needle Exchange Harm Reduction Center, and many that you're going to see throughout the 2 days, remember these groups together are creating access to Narcan, test strips for fentanyl, HIV, HCV testing, linkages and treatment, medically assisted treatment, linkages to detox and drug treatment, medical, dental, mental health access, case management, linkages to housing, and the most important thing, again, building community. And they're doing this very closely with the Department of Public Health. So as I close, I want to thank you for being here, because in spite of all the challenges, going back to community, because community is the one that really is going to influence and impact the way that our communities' health and lives matter. And I want to close by saying the greatest illusion in this world is the illusion of separation. And we say in harm reduction, interconnection is our strength. Thank you so much. I know you're going to have a real fun time the next 2 days. Thank you.
Thank you so much, Laura. It was really wonderful to have a retelling of some of the important history that went into harm reduction. All right, before we move into our final panel, we are going to stream a video for you. For those of you who don't know the history of this symposium, we had originally planned to have it in person and have people come here and then be able to go to site visits and visit some of the incredible organizations that are doing great work in this area to support people who use drugs in San Francisco. But when COVID intervened and made this move virtual, we decided to work with each of 4 different organizations and create a little virtual site visit. So it's not quite the same as an in-person hour-long visit, but you'll get about 5 minutes during each session of one organization per session. So today during this session, we'd like to feature GLIDE, and we're really excited to share this video with you.
Hey, welcome to GLIDE Harm Reduction. We're on the 6th floor, 330 Ellis in San Francisco. My name is Jason Norelli. I am the navigation supervisor for the program. And up here in times not COVID, we normally saw clients at this desk. We provide services such as syringe access, HIV Hep C treatment, and opt-in outreach, which is a van that goes out into the community. But right now during COVID, we're just, we have all our supplies up here, and then we like I've said before, are serving people on the first floor. Hey, so here we are at the Syringe access desk. How are you guys doing?
We're seeing more people in a shorter amount of time. I think being on the ground level has definitely contributed to providing better services for people at needs when they need it.
We're also getting a lot of people that didn't know that we had these kind of services.
And also extending some of the resources and some of the products that we offer to help people during COVID and to stay safe while there's a respiratory virus going on. We have been passing out stems and bubbles for people who smoke so that they will have the ability to not share, as well as foil and straws for smoking as well as for snorting.
Before COVID, we would go out into the community and do testing events and encampments with the city where a bunch of different providers would get together, and we would provide HIV and Hep C rapid testing and then STI swabs and blood draws for syphilis. So the STI tests include gonorrhea, chlamydia, syphilis. For HIV and Hep C, if there were any reactives, people who tested reactive, then we would continue with a confirmatory blood draw and linkage to care after. So the follow-up part would be our navigation program. And we were testing around, I would say around 200 people a month or so, 200 to 250, sometimes a lot more. We don't ask for insurance, so it's super easy to get tested. It's free. It's a free service.
So when someone tests positive for hepatitis C or HIV here, we provide navigation services for them. So we refer folks to clinics to receive care. It can also be medication adherence support, making sure they get to their appointments. Another thing that I'm really passionate about is I think a lot of clients see treating their Hep C and their drug use as mutually exclusive. And that's one thing that I really want to let people know is that you can do both. You don't really necessarily have to change anything. We're just going to maybe tweak a couple little things and just get you right back on track.
Hello, this is Felony Castro. I work for PWID in the harm reduction department. What we do is go out to more remote areas of San Francisco, and for folks that can't come to PWID, then that is my job to follow up with Linkage to make sure there's a continuum of care with their treatment. You have people that can never see a 4-wall clinic and yet get treated. Since we had a lot of people in more remote areas, they were actually safer there, but they still had basic needs to meet. So getting out there with some sort of shelter, whether it was a tent, meals for any of their substance use, clean works, and discussion of harm reduction discussions on how to stay safe. Some of the folks out there already experienced social distancing long before COVID, thanks to society. So we're here to bust that up and to do the opposite. Come out with empathy, compassion. Sometimes it's clothes, sometimes it's socks, sometimes it's meals. Whatever it is, whatever that person needs. Hopefully if we don't have it, we can see if we can get it.
Overdoses are constantly happening. The first responders are actually the clients that we give our Narcan to, and they've reversed more overdoses than probably any EMT in this city. I can't raise the importance of naloxone and giving someone that second chance at life. Nobody deserves to die when there's something that can save their life right at our fingertips.
Thanks so much for watching that. We'll be putting the link in the chat to the YouTube link for that video so that any of you who'd like to watch it again or share with others who weren't here today, you can go ahead and do that. We'll make those available. All right, so to close out the morning session, we have a pretty incredible panel assembled here. The focus of the morning session is really about setting up a linkage to care model that works. And we know in San Francisco that the key to doing this has been collaboration, having people from all different aspects, from the health department, actually involving people who use drugs, people who work in community-based organizations, people who are clinicians, all with their own perspectives and their own important thing that they bring to the table, working together to make services happen. And so that's how we've assembled this panel. We'll be taking each panelist will take about 5 to 10 minutes to share with you some information about their experiences with Linkage to Care and what they've done from their vantage point. And then we'll have about 5 minutes for questions for each panelist before we move to the next panelist. I will moderate those questions since it's such a brief time, just through the Q&A feature. So if you have questions for a specific panelist that you want to ask right away, you can put it in the Q&A, and then I will come on for 5 minutes in between each panelist, take 1 or 2 questions from the Q&A, then we'll move to the next panelist. And when everyone's had a chance to go through individually, we'll bring all the panelists back until the end of the session and have some open questioning at that time. So you can submit questions through the Q&A the same way, or you can raise your hand at that point and we will unmute you and let you ask your question. So with that, I would like to introduce Katie Burke from the San Francisco Department of Public Health. She's our first panelist today. Thanks, Katie.
Hello. Sorry, let me just get these slides up. Okay. Hi. Thank you so much. That video is amazing, Laura. I really loved your talk, and I'm really excited to be on this panel with everyone. So I'm going to focus a little bit on talking about hepatitis C linkage and how our programming in San Francisco has really evolved over the last 6 years or so, and kind of the 3 different phases that we've kind of built on top of each other. I was asked to speak from my perspective as like a health department person and thinking a lot about what my role is, which I think is really a lot of supporting folks like at agencies like PWID, supporting their work on the ground, doing some of the big picture thinking about sort of how everything fits together, and then facilitating a lot of these meetings. So I'll talk a little bit about what that looks like. But first, just a reminder that all these drug user health issues that we're going to be talking about in the next couple of days are really interrelated, and that it's important for us to look at the intersectionality and like learn the lessons from the successes of all the different programs. So this is CDC data on overdose death rates nationally, and also confirmed and projected acute hepatitis C cases. The overdose data are on the left, the Hep C cases are on the right, and the circled portion of the overdose data on the left correlates temporally with the years highlighted with the hepatitis C cases on the right. So really what we're seeing is significant and devastating increases of both phenomena at the same time, right? So our response has to take into account that the same individuals are vulnerable to accidental drug overdose that are vulnerable to hepatitis C transmission. And so our programming really needs to reflect that. Oh, sorry, that's the circle. And so this is my just cheesy Back to the Future reference, because thinking about what hepatitis C linkage services were like in San Francisco back in 2014, we really had very little by the way of hepatitis C services. We had piloted hepatitis C rapid testing at PWID and City Clinic. We had a few agencies that were providing small amounts of rapid hepatitis C testing, but that was unfunded. They were just kind of folding that in with their funded HIV programming. The first curative treatment for hepatitis C, Harvoni, was the first direct-acting antiviral curative treatment for hepatitis C was approved in 2014, but it was really, really expensive. So I don't know if anyone remember the activism about how it was like $1,000 a pill for the treatment for folks. And what that caused was a lot of treatment restrictions to be put in place. So here in California at the time, we had treatment restrictions based on both the severity of liver disease, meaning that folks that were less sick were not qualified for treatment, and also sobriety. So folks that were using drugs were prohibited from accessing these treatments through Medi-Cal. That fortunately has changed in California. Other states still have those kinds of restrictions. So in San Francisco, though, we were really fortunate to have a really extensive community-based HIV testing network. Our community had really adopted a treatment as prevention framework for HIV. So understanding that if folks are treated and virally suppressed, they're not going to pass HIV on to other folks. We had a well-established and growing DOPE project, which Laura talked about. which is housed in the National Harm Reduction Coalition. And we had pretty robust access to opiate substitution therapy in San Francisco. So I really knew that we could learn from all these program models. We could rely on the staff for their expertise, and we can sort of build on what they had already built to expand our Hep C services. So this brings us to Hep C navigation phase 1. So I had spent the first half of 2015 doing a Hep C assessment to figure out, how we wanted to build out a service model kind of across the treatment cascade for hepatitis C. And when the California Department of Public Health funds became available for hepatitis C, we knew already how and where we wanted to scale up our Hep C testing, linkage, and treatment services. So in 2016, primary care was really the gateway to all treatment. And so we defined successful linkage at that time as having successfully initiated primary care. And we were working up to scale. We were also working to scale up our primary care-based Hep C treatment so that folks didn't have to go to primary care and then go to another doctor at the liver clinic. That was increasingly unnecessary with these really effective and well-tolerated drugs. So at the time, we were lucky to be funded by the California Department of Public Health. And then locally, we funded 3 agencies, GLIDE, the San Francisco AIDS Foundation, and Health Right 360 to support folks who are testing positive for hepatitis C in community settings to connect to Hep C treatment. So this was really bringing people to the doctors for care. Occasionally, a doctor would refer an already connected patient to Linkage to kind of help them get through their Hep C treatment. That was a little less common, but that's what that arrow that goes back from primary care to Hep C linkage means. So then we evolved, right? We were doing great primary care-based treatment, but we were also missing all of the folks that were not going to primary care. They were missing out on the benefits of curative treatment for their hepatitis C. But these people were showing up in lots of other places in our service system. So the community started to really develop models to bring treatment to patients rather than bringing patients to treatment. So huge shout out to OTOP, the methadone program at General, the street medicine team. You'll hear more from Leah, Health Right 360. They really, the San Francisco AIDS Foundation, they really started to figure out these models and launch them in kind of later 2016, 2017. And the idea here is that we want to make these programs as low threshold as possible. And we want to offer quick Hep C treatment initiation. So we lose people when it takes too long to get to the medication. These programs are also really reliant on their existing internal infrastructure. And so they were using staffing and leveraging to support these efforts. And they were partnering with us at the Department of Public Health and with End Hep CSF, which is our Hep C elimination initiative. That launched in 2016 too. So everyone was kind of talking together and working together to make these models happen under the leadership of these programs. And you'll hear more about them from our other panelists. And I just want to, Brenda's going to talk more about this, and these data, I apologize, are a year old because everything's really crazy and slow with COVID and I didn't get newer data. But this was from a year ago at our hepatitis C research symposium. And it just looked at, what the San Francisco AIDS Foundation program had accomplished. And, this program is a really innovative model. They have lockers to help people store meds. They give people breakfast to take their program. And they had about 71 folks cured as of last year. I think that's doubled now. And we'll never eliminate hepatitis C without treating large numbers of folks who inject drugs, right? Because that's where the bulk of transmission is occurring. And so these models really start to get to that population and just provide them with the support that they need to be successful in completing the treatment. And then we moved into a new model where we were really trying to follow the lead of community. Because after years of figuring out low threshold linkage models for hepatitis C, we had this kind of growing cohort of folks who had been cured about hepatitis C and were excited about having been cured. And they appreciated, having benefited from our community programs and really wanted to stay connected and involved post-cure. So NTEP CSF received a small amount of funding and developed mini grants to agencies to develop what we called a community navigator model. And we offered training, mentorship, and support to folks who had been cured of hepatitis C so that they in turn could help people that they were friends with, people in their social networks, to get tested and treated themselves. So I think this program has certainly helped people who wouldn't have otherwise been tested or treated get connected. But the other thing that we're really trying to do is talk about changing the culture. how we talk about hepatitis C, and particularly how communities that are impacted by hepatitis C are talking about hepatitis C. So instead of hepatitis C being just sort of an inevitability among communities of folks that use drugs, you know, hepatitis C can be something that you can get taken care of like next week. You could go in and be cured pretty quickly at these programs. So Richard has been an amazing leader in these programs, and he'll talk more about it. And so just a quick evaluation point for, I think, all of these efforts together. This is a hepatitis C infection treatment cascade and 2 rounds of surveys of people who inject drugs in San Francisco in 2015 and 2018. This is a national HIV behavioral surveillance data. And so the white bars are the 2015 study numbers, and the 2018 numbers are like the beige bars. And so what this shows is that in 15%, the folks who inject drugs had received Hep C treatment. And then in 2018, 41% of people had received treatment. Also important to note that these folks were not just people who inject drugs, but also people who are, the majority of them are homeless. And so these are folks that really would be left out of treatment. So we've almost tripled our treatment access among this group. 41% is insufficient. We need to keep working, but it's, I think, heartening to see that we're kind of moving in the correct direction. So just wrapping up a couple lessons learned, I think, again, from the Department of Public Health perspective, you know, you need to do what you can with what you have. A lot of us have been waiting for huge funding opportunities for hepatitis for a long time, and they haven't come. And so we have to figure out what we're able to do without having those kinds of opportunities. I think don't give up on making big systems changes and have plans for funding, even when funding isn't available, so that if something pops up, you know what you want to do with it. I think, you know, Eileen kind of spoke to this, but asking the community what they want and follow through on your commitments. I think when I initially went to a group of HIV testing experts at our community-based organizations and talked to them about what they would want a Hep C linkage model to look like, they were skeptical because they hadn't been supported to do Hep C work previously. But I think, you know, being able to actually follow through and build out those programs in partnership with those agencies was really helpful for our relationship and helpful for sort of us as a community in terms of moving forward in a collective impact model. It's not that helpful to scale up testing if you don't have access to treatment for folks. And conversely, it's not that helpful to open up, you know, treatment access if you're not like testing people appropriately. And so I think thinking about scaling up all of these services simultaneously in whatever way you can is really helpful. You know, I try to be really mindful about helping to create leadership opportunities for community partners and, you know, inviting people to speak and highlight their amazing program efforts. We've got to work harder to share our data about our progress and be transparent about our challenges and for sure celebrate our successes. So that's it for me, just a couple of pictures of some of our community navigators and some of our events over the past couple of years. Thanks so much for your interest and for your time. Oops. Sorry.
Thanks so much, Katie. All right, we have a few minutes for questions. If anyone has any specific questions for Katie, you can put them into the Q&A feature. It should be at the bottom of your Zoom screen. You click Q&A and you can ask a question and we'll have Katie respond. And if not, then Katie will be returning at the end with all the rest of the panelists. And so you can think about your questions and save them for the end. All right, well, I think we'll, in the interest of time, especially since we started late, we'll go ahead and move along. And thanks so much, Katie. We'll now hear from Brenda Cantero, who works for the San Francisco AIDS Foundation, and she'll be talking about this same issue from the perspective of someone working in a community-based organization. Thanks so much, Brenda.
Hi, good morning, everyone. My name is Brenda Cantero, and I'm the Bilingual Hep C Program Coordinator at the San Francisco AIDS Foundation. I'm really happy to be here this morning and be a part of this panel and share a bit about our Hep C programming at the Foundation. Our Hep C Wellness Program operates out of the 6th Street Harm Reduction Center, a syringe access program located in the South of Market neighborhood of San Francisco. The Harm Reduction Center itself is much more than just a syringe access site. It's a place of community and health justice. As we all know, people who inject drugs face high rates of Hep C infection, soft tissue infections, overdose, and other negative health outcomes associated with injection drug use. By providing services and linkage to care on site at a syringe access site, we break down many of the barriers that often prevent people who use drugs from seeking care. We build relationships with participants and honor participants as experts on their own experience. We provide many on-site services such as HIV and STI testing and treatment, access to opiate replacement therapy like Suboxone, harm reduction groups, low barrier substance use counseling, Hep A and Hep B vaccinations, and on-site Hep C linkage and treatment. Once COVID hit and had shelter-in-place restrictions, we had to end several of these activities and alter the ones we could to continue to keep people safe, which I'll go into a bit later. In terms of our Hep C linkage to care, utilizing the principles of harm reduction, our Hep C wellness program meets people where they're at, literally in a low barrier syringe access site. The program is nurse-led and there are no substance use restrictions. So we are there to serve and treat people who are actively using drugs. Our enrollment process is relatively quick and transparent. Our interested participants start the enrollment process by completing a medical screen with one of our nurse practitioners on site. A rapid Hep C antibody test, along with other HIV and STI testing, is conducted. And if reactive, a Hep C RNA test is performed to confirm a chronic infection. Our program intake enables us to get to know our participants, gauge their treatment readiness, and address any potential barriers to treatment they may have. Now, a tremendous barrier that many individuals face when initiating treatment is safe storage of medications. The majority of our participants are unhoused or marginally housed, living on the surrounding streets, encampments, or single-room occupancy hotels. Our community faces significant barriers to care that are based on multiple systemic inequities. And for these reasons, we offer medication storage lockers with enrollment of our program. Our medication lockers keep medication safe and accessible, and participants can access their lockers anytime during our hours of operation to get their medication. And it's also a great opportunity for us to check in and do adherence checks, side effect monitoring, and to address any other needs they may be facing. So from diagnosis to SVR12 and beyond for reinfection prevention and further testing, we provide navigation and support. So we have outlined treatment activities or milestones that allow our participants and our team to track their treatment and program accomplishments. And as an added bonus, the milestones are incentivized with gift cards. So these milestones have also been beautiful tools to empower, motivate, and increase our participants' overall self-advocacy and their journey to health and wellness. Now, prior to the emergence of COVID, we provided a 2-hour Love Your Liver Lounge where participants could drop in for some food, listen to music, and just relax, while also receiving health education, low threshold case management, and harm reduction counseling. It was in our experience that lounge participation greatly improved engagement with their healthcare. Many of our participants have had extremely negative healthcare experiences and have undergone huge amounts of stigmatization. So the lounge and the resulting connections we make with participants is extremely important to build trust and really support people and knowing that they truly are cared for. While the pandemic has temporarily ended our group and lounge programming, we still carry and foster a sense of community and support for all of our participants as much as possible, even if it's from a socially distanced 6 feet away. Now, shortly after San Francisco's shelter-in-place order was announced, we hunkered down, strategized, and crafted ways in which we could continue to operate in a safe and effective manner for both our participants and staff. The outcome was to remain open and establish a door service model where our participants could drop by the Harm Reduction Center, knock on the door and access their medication, complete adherence checks, and get some snacks to go, all at a safe distance from the door. As for the completion of some of our other program milestones, if a participant needs to check in for a 4-week visit with one of our nurse practitioners, needs further screening or blood work done, or just needs to check in and engage with one of us about a need they may have, We then take their temperature, complete our COVID screening questions, and invite them inside. We are currently only allowing one participant at a time. And as of July, we have reinstated our HIV and STI testing for non-program participants, meaning participants that are not yet enrolled in our Hep C program. Since we had to halt our Love Your Liver Lounge, we've been using creative means to keep in touch with our participants in an attempt to cultivate a sense of community. During these uncertain times, we've started further engaging our participants via sending regular texts or call reminders, or dropping off friendly letters and goodies to ensure that we're still thinking of them and care about their health. Now, we've learned some key lessons in providing Hep C treatment to people who use drugs in a syringe access setting prior and during a pandemic. Firstly, and overarchingly, people who use substances can be successfully treated and cured of Hep C. And that's regardless of where people are at in their substance use continuum. Secondly, when we utilize a harm reduction framework and meet people where they're at, it leads to notable increases in positive health outcomes for people who use substances. This is also in conjunction with providing non-judgmental care, navigation, and medication adherence counseling that's rooted in participant autonomy and empowerment. And thirdly, an integral part of our program is addressing and dismantling the stigma and systemic barriers to care that our participants have faced while seeking healthcare in the past. Like I mentioned before, most people who use drugs have had many negative experiences with healthcare providers and have rightfully developed a strong distrust in the system. In response, our Hep C program has created a space led by staff and community peers who provide trauma-informed and non-judgmental care to address the complexities of both individual and community needs, which enable us to not only build trust and connection, but deliver equitable healthcare for anyone who's interested in Hep C care. And as for our newest project, we are planning on going mobile. So we're rolling out our mobile Hep C program soon. This arm of the program will target the Latinx community members interested in accessing Hep C linkage and treatment at select safer sleeping villages, which are city-sanctioned encampments, increasing the health access for the Latinx drug user community that is not only equitable, but comprehensive and culturally competent has been a passion of mine since I started working in harm reduction. So I'm very excited about being a part of this project. So stay tuned. And I just want to thank you again for giving me the opportunity to be here today. And if there are any questions, I would be more than happy to answer them.
Thank you so much, Brenda. It was great. We don't have any questions in the Q&A at the moment, so I'll give people a few seconds to go ahead and put something in there, and otherwise we will continue moving forward, but we will circle back to you at the end.
Absolutely. Thank you.
Thank you so much. All right, so now we will move on and hear from Richard Sullivan, and he is a really, he's been an important member of NHEP CSF and a community navigator, and is here to talk about his experience. Thanks so much, Richard.
Hi, thank you, Shelley, and good morning to everyone. I hope you can hear me. I didn't think I'd be nervous, but I am, and I'm just really honored to be here this morning. I'll try to bring the message instead of the mess, but just to qualify a little, I was cured of hepatitis C almost 6 years ago through Tom Wardell Clinic and Dr. Colleen Egan, a great staff down there, and I was on a 24-week cycle of ribavirin and Sovaldi, and I was cured. And I also live with a comorbidity of HIV. And that started my treatment there. I'd like to give a hats off to the people at Jail Health Services, which used to be FAP, Forensic AIDS Project. They told me I was positive. They visited me in jail, and we saw in some of Katie's slides, that's where some of these things start, in tents, on the sidewalk, in hotels, in county jail. Because I was never, quite frankly, folks, I was never gonna, we're talking about drug users here. I'm an IV drug user. I'm in recovery. I identify as being in recovery. I'm in college. I attend recovery and addiction counseling courses. I belong to NHEP CSF, San Francisco HIV Community Planning Council, a lot of things. SF Hep C task force. I still have, even with COVID, I've managed to keep 2 live community services. I do a syringe access for St. James Infirmary on Friday nights down at Eddy Street, and business is booming. I don't mean to be glib about that, but there's a lot of stuff going on. And also the Now project I've been part of for around 4 months now down on 9th Street, run by UCSF. We get people tested, we get people treated, we get people cured. Really good stuff. And I'm honored to work there. And before that was the San Francisco AIDS Foundation, like Harm Reduction Center, mobile sites. That's down right now for straight volunteers, but sooner or later they're going to pick us back up. And that's where I excel, if I can use that word, because I was on the other side of these tables before. And my life isn't like that today. And that's not like better than, it's just that through wraparound care, just awesome people. Some of it, quite frankly, is lucky. I used to stumble into appointments or not even go, and people stayed with it. Dr. Egan, a woman named Gail Splaver back at the old Tom Wardell. One of the slides we saw earlier about HUD, when you used to be triple diagnosed, that's how I got on, and I'm still part of Shelter Plus Care. I was triple diagnosed, and I got into HUD. I stayed with it because, like we're seeing, we're talking about drug users here. I also do outreach when that was up. And I'm looking forward to doing that again, out in the streets, out in the tents. And that's a delicate balance, because I thought, wow, lived experience, everyone will gravitate towards me. But that's why I'm in school and I'm learning from you folks, because there's a way that you disclose and there's a way that you meet them where they're at. Just because I got well, so to speak, doesn't mean that. So when I go into these outreaches and things like that, obviously I've been in San Francisco 33 years. I see a lot of people that I used to know. And there's a phrase in 12-step, it's attraction rather than promotion. In outreach, you do a little of both, obviously. But people say, wow, Richard, last time I saw you, you had the shit. And that means like HIV and Hep C. What happened? You know, look at you. And that's not, like I said, to boast. It's just, you can see it in their eyes. People want change. Some don't. But I'm getting a little tangent here, but like it's an awesome feeling of responsibility and service to be able to see people you used to know or strangers, and you give them clean equipment. People want that. At the syringe access I'm working at right now, people come in, we're giving a lot of Narcan out, condoms, alcohol rubs. These people are requesting it, clean syringes. Thank God we're there. I go back to the days where we literally, and I'm singing to the choir here for some of you folks, but before even that, the Safeway had the law where you can, when that was new, that was like Christmas, when you could go into Safeway and get syringes. And look what we have now. I came from a time where we used to pass them around rooms. Literally, these needles were like shovels. You used to dent the skin trying to get them in. We'd sharpen them on matchbook covers. That's not to be gross, but that's what we did. Imagine if we didn't have syringe access now. And also on that, I'm a strong proponent of safe sobering sites and clean syringe and clean shooting places. Sobriety sites and the safe injection sites. It's just madness that we don't have these. It really is. I don't care who you are, extreme right wing or whatever. The numbers and humanity don't lie. These places and these themes work. They work. You save lives. I'm seeing, maybe because I'm getting a little older here, but like as I walk the streets of San Francisco, I still live in the Tenderloin down on Eddy Street in Leavenworth right now. And maybe COVID has exacerbated it and made it more visual, but the streets are ugly. There's, with the closure of community-based organizations and things like that, there's unchecked mental illness on the street. Drug dealing is rampant. And I came from a time where I wish drug dealing was rampant. And that's not to be funny either, but it's widespread and obvious. Tents everywhere, and it's just, I don't want to say out of control and like a doomsday prophecy, but it's bad. It's bad, and people are coming in, but there's still people that come into the syringe access. It's like almost like the days of designated driver. There's people, they're homeless, they're in tents, but they come in and they get Narcan. And when we run the checklist down, what was your last usage? What did you do? Where was this? They're saving lives. These people take it upon themselves to watch their friends while people shoot in these streets and things that we walk by every day, and they save their lives. And then they come in for more doses. It's unbelievable. We're seeing humanity on the other side where people stigmatize these things. And I like what the woman said earlier. I'm sorry, I forget the name, but about stigma. Or the gentleman said in the glide slide about stigma. Yeah, in that life, we're stigmatized right off the bat. First, it's self-imposed, and then society. When I was out there as an active drug user, you could smell it on people. They didn't want anything to do with you. And so that's why these services and everything we're talking about here is just so, so important. Like I said, a strong proponent of the safe injection sites, the safe sobering sites, all of that, injection sites, the syringe access, just amazing. My journey started at Tom Waddell Clinic. Dr. Egan used to ease me in. Richard, you know, you have hepatitis C too. And at that time, I used to think that's the least of my concerns. All the things we talk about here in our prevention and how do we reach people, I had those same attitudes. I just wanted dope. I didn't care. I was going to die anyways. I'm on a kamikaze run with my HIV. Just let me, you know, and the gift cards at first, I see it now, but that's how we pull people in. And I don't mean to be glib again. It's a hook and it's an enticement. Gift cards and incentive. Back in the day, until it caught with me, you guys were just something I had to endure and suffer to get the gift cards. I'd listen to anything you said. And I see that mentality today. But eventually, like it's going to be with others, it caught on to me. And I finally sat one day beaten and said, all right, what's going on, Dr. Egan? Richard, we have a treatment. It won't cost you anything. We'll work with you hand in glove. We care. This can be done. We can cure you of this. And I bought in. They were kind. They stayed with me. And then they referred me to Hopwa with Frank Perez. And then they referred me to Project Open Hand so I could eat. And then someone got me an Obama phone. I hate to use that phrase, you know, but wraparound care. And I realize not everyone's up for that. And I got lucky. Sometimes you just walk in the door and the lady says, well, my appointment didn't show up today, Richard, sit down. You're the lucky guy. But it took persistence on other people's parts before I became persistent myself. So I'm talking a lot here. I'll turn it over in a second. Just I used to feel outgunned in a lot of these meetings, and I still do to a way. Stigma goes away slowly, and it's from a lifetime of using dope and being on the other side. I felt stigma a lot, and I you know, that's what it was. But I haven't among you guys. I'm in a lot of committees, a lot of service boards, and you guys have made me feel welcome. And you know, so I don't feel outgunned here because I'm trying to do something about it now. You know what I mean? And so that's the deal. I just empathy, compassion. I just used to think things were bywords like, you know, meet people where they're at, but that's what it's all about. These people trust me and all of us after a while when they see that there's disclosure slowly in some of these studies I do. You're at the desk. You don't want to just, you know, strangers or, but sooner or later they know you're in the life and they kind of get you to the side and say, really, what's up with this, Richard? I say, man, this works. This can be done. What else you got to do today? You know, stick around, listen. I guarantee this works for you. So that's all I have today. And thank you very much, everyone. Thanks for having me here.
Wow. Thank you so much, Richard. I always love hearing you talk. Thank you so much for your leadership and your willingness to share your story. It's really so valuable. And I hope you're, when you're done now, that you're able to take a look at the chat, because you're definitely getting some love from people in the chat. All right. Well, I think we're going to move on to our final panelist, who is Leah Warner, a nurse practitioner with the street medicine team in San Francisco. And we're really excited to have her share her perspective as a clinician, and then keep sending in those questions. We'll go back to the questions afterwards. All right. Thanks so much, everyone.
Okay, thank you so much for having me. I am also totally nervous. So I'm Leah. I'm a nurse practitioner with the street medicine team. So that means I work for the Department of Public Health on a specialized team where we provide primary care to adults who live in San Francisco and are experiencing homelessness. So before I dive into what I'm going to talk about today, which is like, I'm kind of like on this like amazing Hep C work, but I'm just going to try and stay as relevant as I can. I'm going to talk a little bit about homelessness and like why we even use this word, what it means. I think Ms. Maya Angelou sums it up really well when she says that the ache for the home lives in all of us, the safe place where we can go as we are and not be questioned. This obviously is like the ideal experience of home. It's more than just like a place where you live. It's actually a place where you belong and can be yourself. And I think the patients who I take care of have really an opposite experience from this. There are really very few places people who are experiencing homelessness can go and not be questioned. I mean, questioned all the time, really not welcomed in a lot of our public spaces. And by definition, don't have a private space to go and be themselves. So I use this kind of as a guiding principle. I mean, that's, I think, what we talk about when we say, you know, housing is a human right. I think that really guides how I think about this. And so I'm going to try and touch on like, well, what, you know, how does someone get to this experience of homelessness, these structural forces, big picture, down to like, what, you know, why do we see so much disproportionate illness and disease? Why is that a common experience in the people in our community who are experiencing homelessness? And then I'm going to talk about how healthcare can do something to address some of those gaps, especially in how the services provide access to care. And I'm going to focus, instead of Hep C, a little bit more on Suboxone, or also known as buprenorphine, which is a medication-assisted treatment for people who are using opiates. And that's sort of been a big focus and project of the street medicine team. So just starting out with homelessness, you know, this is a mix of discrimination, generational and systemic, racism, sexism, mix that in with poverty, get some policies in there, and we have people experiencing homelessness. And throughout this talk, I really talk a lot about how people have sort of this increased vulnerability and these high risk conditions. And just like nobody is, you know, intrinsically homeless, this is not a characteristic. Nobody is intrinsically high risk or vulnerable as a person. These are really the results of these kinds of bigger systemic forces that create this situation that now we are talking and thinking about. So let's look at homelessness. You know, we have about 500,000 people experiencing homelessness in the US, and look at California. Okay, ooh, that didn't work. Okay, well, I don't know, my animation is all messed up here, but in California, we have about 12% of the US population, and we have over 25% of the US population experiencing homelessness. So we have over half. And the same thing is true of San Francisco. We have about 2% of California's population and about 5% of California's homeless population. So homelessness is a thing. It's a thing in California, and it's a thing in San Francisco, and it's here in our community. And when you look at people who are experiencing homelessness, the amount of disease and disability that this community is going through is so disproportionate compared to just the general population. So if you can see on this slide, you know, the green bar is our US homeless population, and you can see just the amount of disability, traumatic brain injury, substance use, and mental health. And I want you to picture a patient, a client, dealing with all of these things, because that's actually quite common. Somebody who has traumatic brain injury, so a cognitive processing disability, right? On top of being disabled and on top of using a substance, and throw in depression, PTSD. Now think about this person trying to access healthcare in our system of care with all of these things going on, walking into a clinic, being asked for ID, all of those things, right? So it's it's something we really, really, truly think about. And this, if you'll excuse me, I'm just going to skip over here and come back to this. But when I think about it, this slide is not in the right order, but I'm going to hop around. So when I think about that patient, I really start to think about the barriers to care. And I don't think it's fair to talk about barriers without talking about them from the provider perspective as well, right? We always talk about like, well, what is this patient's barrier to accessing care? It's like, well, what is the provider's barrier to providing care? So I often hear from patients that they really can't trust these providers with their story, with their lives. I mean, going back to that Maya Angelou quote of safe places to go. And I hear that providers are often like, oh, well, what's the point? Patients won't stop using substances. You know, they won't adhere to any of the plans I come up with. So you can see already this is like we're set up with attention here, and we wonder why our patients don't trust us, you know. But patients often feel like they can't get to an appointment, and providers feel like, oh, they will not be quick. They will not fit into a 15-minute slot. I only have 15 minutes in my primary care panel schedule. And then I think accessing medications always come at the end of a visit. There's always a prescription, and getting that medicine and providers believing that patients will take that medicine. These are some of the barriers that set us up for real challenges and real kind of mutual distrust in a situation where we actually need to create an environment where people feel welcomed and people feel trusted. Now I don't even know where this is going to go from here. So I think that is really where we get some of these health disparities, right? We're looking to create safe spaces for people where they actually feel welcome. And we're looking to really meet, you know what, I loved our last talk about what Richard said about meeting people where they are. It's like, what do these words actually mean? But it is true. It's like understanding how challenging it is for a person who's experiencing homelessness to get to a medical appointment. You know, I mean, that's not true for everyone, but thinking about, well, who's going to watch my stuff, and how am I going to get from point A to point B, and in what time frame? Walking through the door, I am often very, very happy to see my patients, because I kind of know the challenges that it takes to get them from point A to B. And that is about accessing treatment. And that is about acknowledging like that this treatment, this medical care, it's actually, you know, these are our clients, these are our customers. So we actually have to make that known, that we are there to provide this care and there to enable people to access treatment. Okay, where am I going now? So I think that leads us to this, oh man. Let me go back to here and just talk a little bit about the street medicine team. I'm so sorry, this is not the right slide deck. So the street medicine team, we are a part of San Francisco Department of Public Health. So we are the government, and we're a multidisciplinary team. And really what we do is we focus very specifically on, actually, I'm just going to try for a second to see if I can find the correct slide deck here, because this is actually important. And I will try and like talk about street medicine as I multitask here. But one of the things that street medicine does is we really do try to break down barriers and think about how to break down barriers for people to better access their medical care and addiction medicine treatment. So one of the things that we've been really focused on in street medicine is lowering the barriers to accessing a medication called buprenorphine, which is a medication-assisted treatment for people who are using opiates. And we have really tried to improve the access to this medication. So, you know how you work on your slides and you get all attached to them and they're just like, they're perfect the way they are. And now all of a sudden I just have to be able to move on away from them. So, and now I've totally lost them altogether. I am gonna just go on without them now. Okay, so you may have heard that we are in this opioid epidemic in the US that people tend to think about in 3 waves. The first wave coming in like the late 90s when there were a lot of prescription for opiates to treat people's chronic pain. People were actually dying of overdose from those prescriptions, and then providers stopped prescribing opiates and pulled everybody off of their opiates, and then we saw a wave of heroin come through and overdose from heroin. And now we're in a 3rd wave, and we are still in that wave of synthetic opiate, which is often known as like fentanyl or some of those analogs. And if you look at the data, and I will send out my slide deck because I have it in there, in San Francisco, one of the amazing things about San Francisco is that our death rate from opiate-related overdose has stayed pretty even throughout those waves. And the reason is really because, or we think the reason is because of the amazing harm reduction efforts that San Francisco has been able to do with naloxone for sure, and then also medications like buprenorphine, methadone. These are medication-assisted treatments that really do help prevent overdose and death. And that is why the street medicine team really has this project of lowering the barriers for people to access buprenorphine easily. And we think about this in 3 really important ways. The one is get rid of appointments. Don't have appointments for, we often say that they're kind of like the enemy of people experiencing homelessness, because what happens is somebody misses their appointment and the first thing they're told is you missed your appointment. It's like, well, I made the effort to come here. So we really try to have just chunks of clinic time in which people can access our medical care. And then we put our medical services in all kinds of non-traditional settings. And I think Katie talked about this a little bit in her presentation, but we do have a home-based clinic, but we are also in syringe accesses, encampments, we're in navigation centers, shelters. I think I'm even at the Drug Users Union once a week. We're trying to be in places where our patients feel welcomed already, in those very sacred spaces within San Francisco where people do feel welcomed. There we are. And then the last thing that we do is we take a harm reduction approach. Our whole team is very committed to that. And the way that we keep moving forward with that is to have a very multidisciplinary team that can put checks on everyone, because providers, I think in particular, can get very tunnel visioned around like, what is this prescription and when is this patient coming back? And you really need different perspectives on a team to say like, well, I see this change in this human, so maybe we could think about it that way. And that I think really does keep us in a way in line with harm reduction values, so that we're not just saying we're harm reduction, we're actually trying to live it, because it can be very challenging in a dynamic where it's set up that I'm writing a prescription and a patient is receiving that prescription. And so that's how we on street medicine have really tried to break down those barriers. And I want to say one more thing, and it is really a shame that I don't have my slide deck because this is a visual part of this presentation, but we still face a very important barrier when it comes to buprenorphine. And that is that in the early 2000s, when buprenorphine was sort of rolled out and advertised, there was a very white and affluent face on the advertising of this medicine. And it was really marketed to people with private pay insurance or pay out of pocket, and a very white audience. Like all the pictures of the early advertisements, and you would see this, are of sort of like white and affluent people. And today in 2020, there is good research to suggest that most of the patients who are on buprenorphine tend to be white, tend to be privately insured and tend to or pay out of pocket for the medicine. And that if you look geographically at where buprenorphine prescribers are, because it does take an extra license to prescribe this medicine. If you look at where those prescribers are concentrated, it's mostly in white and affluent areas geographically. And then if you look at where communities of color are, you're going to see more methadone clinics concentrated. And so all of a sudden, you know, opiate use disorder, which has no racial preference whatsoever, becomes this sort of, there's this legacy that's handed down. I think that starts with the story of how buprenorphine was explained to the medical community and to the community at large. And that explanation, I think, still has a lot of teeth in how both patients think about it, and more importantly, how providers think about this medicine. So, if you look at actually, like I said, the death rate in San Francisco has actually stayed pretty steady throughout all the different waves of opioid epidemic. But what is also true is we see Black Americans, African Americans disproportionately dying of opiate overdose when compared to Latinx and white communities. So this is a huge problem, and I always am talking about it in any public space I have to say that we need to do better. Street medicine needs to do better. We all need to do better when someone has an opiate use disorder, to be talking about all the options, including buprenorphine, which I would consider life-saving medication for anyone who's open to taking it. And then the last thing I'll say is about resilience. And I think I really try to talk a lot about the strengths that people experiencing homelessness bring to our world around us. And for anyone who is in this system of care, whether you are a policymaker or, you know, a clinician who's documenting, or how you speak about it, pretend that the person who you are speaking about is sitting next to you, because how we represent, how we voice for people experiencing homelessness in our community who often don't get a seat at the table or don't have like much of a voice in our systems of care, like those barriers we discussed in just even entering a clinic, how we talk about it is really influential. And so when I'm charting, especially when I'm charting on my patients, I am really thinking about how would Mr. Smith here want to be represented in this here like computerized system, you know, that to me is really, really important. And that will, I'm sorry, I lost my slides, and I will send them out.
Great. Thank you so much, Leah. It's dealing with technology can be so challenging sometimes, but you know, in harm reduction, we learn we have to be flexible. We have to roll with the punches. So thank you for modeling that, especially in the time of COVID, right? We can't always control it. So thanks. All right. We have 20 minutes left in this morning session. So we're going to bring the other panelists back to the screen, and we have a handful of Q&A questions that have been submitted through the Q&A feature. And I'm going to go ahead and ask those to the panelists. If any of you out there in the audience have additional questions, you can submit them through the Q&A feature, or you can raise your hand. There should be a raise your hand button at the bottom if you would prefer to just ask directly and have us unmute you and have you ask a question of the panelists. So go ahead and do that. And in the meantime, I'm going to start with a question for Brenda, actually. Someone is asking if you can talk more about the Liver Lounge.
Hi, absolutely. So the Liver Lounge was a space that was kind of conducted like daily at the Harm Reduction Center from 11 to 1 p.m. And it was just like a space for our clients or participants to just hang out and just relax and listen to music and eat some food that we had. There was like no pressure of us asking any like health questions or anything. We would just like have conversations about what was going on. We would watch YouTube videos. It was like a really nice, warm space. However, there was access to the medical team as well, if there was any like needs or questions that they may have had. And yeah, it was just like a great place to connect and meet new people, and maybe even connect with others who were going through the treatment process as well. So it was just like a really friendly, warm place that we really, really miss. So we're hoping that after, when COVID transitions, whatever happens, we can go back and have that space again for our participants, because it's been really challenging, I think, for all. So yeah.
Thank you so much. All right, this next question is for you, Richard, and that is, what alternative ideas do you have for engaging people who use drugs when incentives and gift cards are deemed unallowable program costs? So if you're not allowed to do that, what could you do? What are some other ideas you might have?
That's hard. That's kind of hard when you take the carrot away from the stick, honestly. But yeah, so that's the reality nowadays, especially with funding and things like that. But bottom line is, like we've been all talking about in the harm reduction, just being kind to people, who they actually see in their dealings. So like when community-based organizations open up again, outreach people go out and start doing the hand-to-hand. It's all right, so these people don't have incentives. Their idea, like, why the F should I care? Well, the people that they're interacting with on a daily basis. Hey, how you been? How's your wife? How's your dog? You know, you see them in the tents and stuff. Is there compassion? Because quite frankly, when we look at the streets right now, when we look at homeless, I know it's unfair to compare this way, but who are they surrounded with on the sidewalks? Dope dealers. Imagine if those were caregivers. And I know logistically it can't be that way, but they're surrounded by people that are just doing them wrong. And that's where they find their solace. Anyone out there struggling, none of us are there right now. They're just seeing a handful of crack dealers. That's their coping mechanism. And just to end quickly, maybe, I don't know the numbers behind this, but like with the shelter-in-place hotels that are going on now and the enclosed tent cities, I see this as an opportunity, however it can be done. We finally have an elusive demographic that's corralled, so to speak. I don't know if there's like groups going on in there, or like sometimes psychoeducational groups are a little too much, the Blackboard thing, but just drop-in rap sessions. You know, once this opens up again, like organizations, send people out to the SROs. Just announce, maybe no one will show, but just have rap sessions in the community rooms. Let them know that you care. Let's hear their beeps. Just who they see every day and how you interact, and do they trust that you care?
Thank you. Thanks so much, Richard. Okay, next I have another question for Brenda. Can you talk about how participants have reacted to programmatic changes during COVID?
Yeah, so I really like the bit about Leah mentioning resilience. I've seen, I think from all aspects of our program, we've seen a fair amount of resilience in terms of how we've really adapted to all these changes. At first, it was really hard, I'm not gonna lie. People were like used to our Love Your Liver lounges and accessing the space because it was their space and it was really beautiful. And like everyone was really friendly and they had bathroom access and food and all these like great things. So it was very challenging having to take that away. And you could actually see that on the other end as well. So a huge challenge that we encountered was losing track of people. Like people just weren't coming because they needed to go elsewhere to seek shelter and safety. And we weren't that anymore for the beginning of shelter in place. So that's why we had to kind of scramble to find ways to get remnants of that back and start building community again in these like really crazy times and uncertain times. So yeah, it was really difficult. People were a bit irritable, but completely understandable. we were trying to work with them outside and providing as many services as we could at a safe distance outside the HRC. And so I'm really happy that we've transitioned to more indoor activities that are also safe. But yeah, that was the initial response. And as the months have passed and gone by, there's like this, like, again, understanding and adaptability that's just like so human, and resilience that is just beautiful to see on everybody's part. And that's where we're at, yeah. But it's been really challenging, but we're doing it, and we're excited to be there.
Thanks. All right, Leo, we have a question for you. What advice do you have for a syringe access program that is opening up its first MAT program?
Give the prescription for the medication, Suboxone, if you're prescribing Suboxone, give the prescription the same day. Start it that same day. That would be my biggest piece of advice. Don't do the thing where you have the patient come in and tell you their story and say, okay, I think that this medication is a good fit for you. Let's start this medication. Come back in a week and show me that you really want it. You know, or like, this was just our intake. Now we're going to start, you know, with a medication like buprenorphine, Suboxone. The way I think about it is that it's has a really high safety profile, and it's life-saving. So we really see it preventing overdose deaths, and I think almost never see it as the cause of an overdose. At least here in the US, we haven't seen that. So if you think about it that way, and you think about giving a small prescription to start, I think that is really key. Better than saying, come back and then we'll start it after we go through this intake and you meet with our social worker and we learn all about you and then we have you come back. I think people who are in that place of like, I'm willing to talk about this and I'm willing to try something new, that's the time. Try it. Try something new.
Great, thank you. All right, Brenda, we have one more for you. You're very popular. Can you talk a little bit more about what your mobile platform entails?
Yeah, absolutely. Great question. So we are, like I said, planning on rolling it out relatively soon. We're still kind of working a few things out, but what we envision is having all the services of our Hep C program on a mobile van and just hitting the community straight on. So we would have a coordinator there driving the van, a phlebotomist, and a nurse practitioner, alongside lockers in the van as well. And we are going to safer sleeping villages, and just engaging people via outreach currently, just like providing safe injection, safe smoking, and hygiene supplies. And also like trying to gauge if there's any interest in treatment and testing. So that's kind of like what we're currently doing. If we see that there's interest and excitement even, then we're gonna target people who are ready to start. And that's what really has been the driving force of us getting mobilized, really, because we are seeing a lot of interest, not only in just like treatment, but like other services that our syringe access site has and is able to provide. So it's really been a great endeavor of just like me getting to the city, and getting to know a lot of people in the community, and just, you know, exploring the different facets of our program has been great. So that's what it will look like. I'm thinking we'll have more details in a couple of months. So yeah, that's why I say stay tuned.
Thanks. Before you go, there was a follow-up question in the chat about how would the van be labeled? What would it say on the outside? Maybe you can talk about your van at least. Yeah. Yeah, so currently it'll be one of our outreach vans that the foundation has. So they are just white vans. There is no signage whatsoever. We do have sometimes magnetic signages that are attached on the van, and it has our Hep C logo. So live free from Hep C,
with like our contact information on it, but that we can take off or we can put on. So it's not really on the van at all times. But we've actually gotten a lot of interest with that magnetic template that we have. And also our visuals are really awesome. It's like a rising phoenix. So it would be a great tattoo. And yeah, so we're pretty flexible with signages. Right now, it's just usually a white van.
All right, thank you. I need to, I have one more question to ask, but I wanted to just remind everyone we have enough time for probably another question or two. Oh, good, I see another one coming in. So please go ahead and put your questions in the Q&A feature. It's a little hard to check on the chat, the regular chat, but if you put them in the Q&A feature, or you can raise your hand and we would be happy to unmute you and have you ask directly. I'm going to actually go to Katie for the next question. Someone asked a little bit earlier, basically that from their county, they're just getting started with hepatitis C initiative in their county. And what advice do you have about someone who's just starting to figure out how to get this started?
Yeah, thank you. I think one of the most impactful things that I was able to do early on was kind of seek out the providers that were already leaders in Hep C treatment for folks that use drugs or people experiencing homelessness, and try to really connect them with the community, syringe service programs, the early Hep C linkage programs that we funded. I know Richard talked a lot about Dr. Egan, who was a really big champion for Hep C treatment in primary care. And really, someone asked about the Back to the Future reference in my slide, which was just like a time travel reference. But thinking back to 2014, when the Hep C medications were still new and we hadn't done a lot of work around primary care-based hepatitis C treatment. If you were a person experiencing homelessness or a person who used drugs and you wanted to cure your Hep C, like that was probably really only going to happen if you were lucky enough to be linked with a handful of providers in the city that were doing this work early on. And that was like Dr. Egan, Dr. Lukemeyer at Positive Health Practices, Dr. Andy DeRusso at Health Rate 360, Dr. Joanna Eveland at Mission Neighborhood Health Center. And so I really kind of targeted them in our talking and thinking about expanding our linkage services, and started to Dr. Serlin now, Dr. Lynch then is another one of them. And one thing we did with her, for example, was bring her, she was curing Hep C in primary care at Southeast Health Center in the Bayview. And we brought her to the Bayview Hunters Point Foundation methadone program. And she sat with a group of patients there and she said, yeah, I can cure you guys, just come see me on Wednesday. And those patients, we had a meeting at Southeast afterwards and we saw 3 patients from that presentation lined up to make an appointment with her. And so I think kind of helping to get those clinical providers out into the community and connected with the community services was really, really key, and opened up a lot of room for new partnerships and more effective program models. And I think that works conversely as well. And so just want to acknowledge Orlando Chavez, who is an important member of Hep CSF. He's since passed away, but he was a Hep C navigator at GLIDE from the beginning of that program there. And I used to bring him everywhere. If I was doing a quick talk at a methadone program about Hep C treatment, I would just kind of bring him and stand back and let him talk to folks about his experiences. And so I think that connects to my lesson learned about creating leadership opportunities. And so I think that can look like bringing folks to like these panels so that they can talk about their amazing programs, but can also be bringing people to other places in the city to kind of present on what their programs are doing or talk about their personal experience the way like Richard did so movingly. And so I think kind of making those connections and taking some ownership of that process as a health department staff has been really helpful for me.
Thanks so much. Okay, I think we have time for one more question, and we have one more question in the Q&A, so that's perfect. And this one is for Leah. So Leah, can you talk about microdosing buprenorphine, your thoughts on the experiences of participants, especially those that were primarily using fentanyl, and the general landscape, whether other providers are familiar and utilizing?
Questions? Oh, this is a favorite question of mine. I also see in the chat, someone wrote like, oh, well, they may not be able to start the Suboxone right then and there the first day because of precipitated withdrawal. I should clarify, on street medicine, we are not walking around with Suboxone and giving it to people. We don't carry the medication. It's a controlled substance that would require a lot of licensing that we don't have. We are writing prescriptions. So I meant give a same day prescription on that first day. People then take it to a pharmacy and redeem it. And one of the greatest things we have in San Francisco is this community behavioral health pharmacy. It's a city-run pharmacy, and it will honor the prescription for Suboxone and other mental health and substance use treatments. It will honor that prescription regardless of insurance and regardless of having a photo ID. So for anyone who can build a relationship like that with a pharmacy and reduce that barrier, like I said, accessing medication is such a thing for people experiencing homelessness. Having an ID is such a thing. Getting rid of that barrier is huge. Now, microdosing, favorite topic. So starting with people who are using high dose fentanyl and having some difficulty getting from using high dose fentanyl to on Suboxone or buprenorphine. And so for those who don't know, the timing of when you start buprenorphine is important if someone is using opiates. And you do need to wait before starting the medication so that you don't precipitate a withdrawal, cause somebody to go into withdrawal. And in the microdosing idea, what happens is people continue to use whatever they are using, high dose fentanyl, for example, and start to take small amounts of buprenorphine, and then transition over that way into reducing their fentanyl use and now taking a full dose of the buprenorphine. So do I think that clinicians are doing it? I will just speak for myself. I rarely do that. I have some patients where I think it makes a lot of sense, and we are working closely with that pharmacy that I just described to create very easy to use like bubble packs, but it's kind of a complicated thing. It's like day one, do this, day two, do that, and people have a certain level of anticipation around taking this medicine anyway. So it can be a little daunting to microdose, especially in the patient who is feeling very nervous about the transition. And oddly, that's usually the patient I think about doing it in, right? For most of my patients, even those who are using very high dose fentanyl, they kind of take care of business and get on the medicine themselves. And it's one of the great things about non-facility based starts of this medication. Traditionally, when someone wanted to start buprenorphine, they would like go to a facility and be watched and be like, okay, sir, now you are in withdrawal, you will take this medicine. We just give the prescription to a person and say, fill the medicine, take it when you're ready. We do some counseling around that. And 9 out of 10 times, that's what really works. For the 1 out of 10 time when people are feeling like I can't take this medicine, it keeps making me sick, even though I waited, even though I did what you told me to, nurse practitioner, I think about microdosing, and I think it's a longer discussion, and I think it takes a lot of counseling, close follow-up. So that's how I would answer it. And the whole idea of microdosing really did come out of how tough it is to transition from a medication like methadone or high dose fentanyl onto buprenorphine. And honestly, in my patient population, it comes up very rarely. I feel like my patients really know what they're doing around getting on their medicine. So I've only done it a couple times. I hope that answered the question. I believe in microdosing. I do believe in it. And I think we should be ready to do it for the people who need it. We should be ready to do anything if somebody is wanting to try something new. We should have all the information ready to go. That's how I feel.
Well, thanks so much, Leah. That's a great note to end this session on. So thank you so much to all of our panelists and presenters today. Thank you to all of you in the participants for joining us today. Those of you joining us for the next session in 1 hour, the links via Eventbrite should be fixed now. So if you had problems before, we apologize, but it should be fine for the next session. We'll be talking in an hour about strengthening relationships with unconventional partners. And it's going to be an important session, and we really hope to see you there. If you haven't already registered for that session and had such a good time now that you want to register, we've left registration open, so you can still do that. So in closing, I just want to thank the National Association of City and County Health Officials, NACCHO, whose funding made this symposium possible. And we really are grateful for their support of this work. And to let you know that at the end of the whole symposium, we'll be sending you a link with an evaluation for this session and the rest of the sessions during the symposium. And we'd really like for you to take it. It's short and it'll help us learn and get even better for the future. So thanks again so much to all of you. We really look forward to seeing you in an hour. Take care.